Today's week 4 of this series, and welcome back.
Thank you.
And today we're going to talk about a bit of a heavier topic, which is advanced directives and the life, recognizing the limits of medicine. Same disclaimers as last time. So, why is this important? Well, we don't get to choose how or when we get sick or injured. It just happens. That's life. So because of this, it's important to have at least as much say as we can in what happens when we do get sick or injured. And this is where advanced directives come in. So we'll talk about that throughout this session. It is not wise, in my opinion, to wait until something happens to do this. It is much better to be proactive and get things in place, documents in place. Make sure you express your wishes ahead of time, because it's not only about ourselves as individuals, it's also about our loved ones and family. Because if we don't have these things in place, they're the ones who have to do something about that and suffer all the more because of that in an already probably stressful situation. So what are advanced directives? So advanced directives are written instructions about our future medical care. And typically this is in the event that we are unable to speak for ourselves. So if we are sick in the hospital and we're too sick to make, decisions that make sense to us or to anyone else because of our mental state at the time, then this is where these documents kick in. The most common one is the healthcare power of attorney, or HCPOA, POA for short, usually. And another one is a living will. And we'll go through these one by one. Now, I think every adult should have these already in place as soon as they can. These are very straightforward. They don't require an attorney to get in place. And they should be updated periodically, as life changes and contact information changes and that sort of thing. The website that you can access these pretty easily from is the Sublette Hospital District website listed there. And under the Forms tab, you'll be able to go to the Power of Attorney form and just print it out. Same with the Power of Attorney form that is in the website includes a living will within it. So that's all included. So what is a healthcare power of attorney? This assigns an adult or more than one adult whom you trust to make healthcare decisions for you if you're unable to make your own decisions during an illness. It gets activated, meaning that it doesn't do anything until you are unable to make your own decisions. So, of course, if you are already able to make your decisions, then you're asked directly about those. So it only gets activated when that ceases to be the case. Without it, what happens is if you don't have a healthcare power of attorney that says X person would make decisions for me in the event that something happens to me, I can't make my own decisions, then legally, at least in the state of Wyoming, this is the order in which next of kin goes as far as making decisions. So it starts with your spouse. Then if that person is not available, an adult child, then parent, then grandparent, then sibling, then grandchild. Then if none of those people are available, then the person most closely familiar with your values. This is, as the Wyoming statute states, quote, an adult who has exhibited special care and concern, who is familiar with the person's personal values, and who is reasonably available, end quote. So that's kind of the last in line of those people who are accessible. Now, of course, this is a less than ideal situation because it may not be that that person in line is the person you want making decisions for you. It may be so, but it may not be so. And it's better to, in my opinion, to choose who makes those decisions up front by you than to let the system choose for you by default. It also allows you to express your wishes ahead of time. Usually there's a place there for you to free text and write any specific wishes you want, whether you want something or don't want something explicitly when you're in a very sick state. And this not only helps healthcare providers follow your wishes, but it also helps ease your loved ones the stress that comes with being sick. And that way they know, what you want ahead of time. It also reduces potential legal headaches because if this is not established, there's certain circumstances where a legal guardian has to be established, and that has to be done by a judge. So that's a whole other process that could be avoided, not only the stress, but also the cost. You can choose whoever you want to be your power of attorney, as long as that person is an adult and ideally consents for you to be choosing him or her for that. So some important caveats to these to this document. So if there's a divorce, then that divorce revokes the previous designation of a spouse as your agent to make decisions for you, unless it's specifically mentioned in the power of attorney. So that's important to keep in mind. Another important thing is signing a new healthcare power of attorney revokes the previous one. And then an important thing to keep in mind is that doctors are liable if they willingly and recklessly disregard the wishes stated in a healthcare power of attorney document. Of course, this is assuming the doctors have access to it. So that's first step, obviously. But assuming they have access to it and the stated wishes are plain and clear, then the doctors are liable or are bound to comply with it. The exceptions are if the stated wishes violate the law. So sometimes people may put things down on a document that would violate the law if complied with, depending on where they are. So in that case, the doctor doesn't have to comply with that because it would be violating the law. Another exception is if the wishes are contrary to standard of care. So for example, if there's something that is stated that completely goes against a rationale as far as known medical standards of care, then the doctor or provider can legally decline to follow that. And then a third one is if the request or wishes require ineffective medical care, meaning that if the wishes are followed as stated, it's almost for sure known that that will not lead to effective medical care. There are dozens of examples of what that could be, which is why it's important to go over this document with your own primary care doctor. Because if you write something and you want to make sure that it makes sense in the context that if something were to happen to you, then it will be followed reasonably. So oftentimes it's hard for folks to know this offhand, but you can always just ask or try to ask your primary care doctor if there's doubt as far as if you're not sure that what you put down will be followed. Now, if the doctor who's taking care of you, let's say, for example, in a hospital, during a time when this is invoked, the power of attorney, if that doctor is not willing to follow your wishes, then he or she is obligated to immediately transfer care to a provider who would be willing to follow those wishes if those wishes are not being fulfilled out of a conscientious sort of objection at that point. Now, a living will is a little bit different from a healthcare power of attorney. These can sometimes be confused. So the living will is more a set of instructions that are followed in the event that you develop an illness or injury that cannot be cured and will lead to death. So a classic example of this is if someone's in a coma and there's not an expected recovery from it. And another way to name this is a persistent vegetative state, which means that your brain is damaged beyond what a reasonable doctor would see as having a chance to recover. In these cases, which are not very common, but they do occur, that's where the living will kicks in. So these are instructions about the use of life-sustaining treatment. For example, being on a breathing machine, whether you do or don't want to be on one if you're in this situation, a feeding tube, dialysis, blood transfusions, et cetera, et cetera. So oftentimes documents will prompt those questions as to whether you want these procedures done or not. And then you get to, express those wishes. And like I said, this is included oftentimes with the healthcare power of attorney form. So it all comes in one packet oftentimes. Now, another related, but certainly different set of documents or decision-making is something called code status. So code status is kind of the medical short-term or short way of saying whether someone would like to have CPR, meaning cardiopulmonary resuscitation, meaning that they're brought back from a cardiac arrest situation. I'll go into that a little more, or if they do not want that. So CPR is started when there is no pulse and there is no breathing. It includes chest compressions. That means pushing hard on the chest. The chest has to be pressed deep enough so that the heart gets pumped. And this usually breaks ribs. It's almost expected that it would break a rib because you have to push on the chest so hard. It also includes potentially using an electric shock to try to regain a normal rhythm of the heart. It includes artificial ventilation, which means putting someone on a breathing machine, and it includes giving IV medications. This is all in one packet. So when someone loses a pulse and is not breathing, is down, unconscious, typically CPR would be started unless that person had previously stated and has in writing that he or she does not want to have CPR done. So the medical system assumes that CPR is the default. And this is often called full code. So that means, that CPR will be done. Now, if someone does not want that to be done, then that's called DNR, or do not resuscitate, also sometimes called do not attempt resuscitation. This only applies if there is no pulse and no breathing, which means that this does not apply to other situations where you might be sick, but you still have a pulse and you're still breathing. But it's specific to that one event situation, which means that if someone decides to be DNR or to not have resuscitation, it doesn't have any bearing on other forms of healthcare outside of that situation. This is important to know because sometimes people confuse someone not wanting resuscitation with not wanting other medical care, and those two things are very different. Someone can still want other medical care, for example, getting medication for their blood pressure or treating an infection or treating an injury otherwise, but may not want to be resuscitated if they have no pulse. And that's fine. Those two are separate decisions. It's a very individual, personal decision. The form that is signed if someone does not want resuscitation has to be co-signed with your medical provider. So it has to be discussed with him or her. Typically, it is a primary care doctor who signs that and is in a discussion with you about that. But it can be any doctor that you see and that knows you and that has provided medical care for you. Doesn't necessarily have to do primary care doctor, but most of the times it is Now, one very important thing that I go through with people when we're having this discussion is realistic expectations. So one of those is just asking ourselves, how successful is CPR? It turns out it's not like the movies. Um, in the movies and TV shows, oftentimes CPR just almost magically revives someone, and they go on their merry way. In reality, only about 18% of people who get CPR survive to be discharged from the hospital. That means over 80% of people die in the hospital after such an event. And when you think about it, it kind of makes sense, because if you don't have a pulse and you're not breathing, you're not getting oxygen to your brain. And if that lasts long enough, then that will eventually lead to death. And so that's why it's such a low survival rate. A lot of it depends on how quickly someone gets CPR started. That's number one. Number two is what caused the event in the first place. If it's a massive heart attack from which there is no turning back from, well, no matter how much CPR there might be, that might be it. If it's something that's reversible, like let's say, for example, if there's an electrolyte abnormality and that can be fixed, then the chances of surviving might be a little higher. But all comers, that's about 18% survival. Those with sepsis, meaning a massive infection, or advanced cancer, or dementia, their rate of survival goes down to about 5 to 10% or less. Again, because the body is already weakened by these other things, so the survival rate will be lower. If the life expectancy is less than a year, for example, because of cancer or some other illness, then the chances of survival from out of CPR after a CPR event are less than 5%. So these are all important things to note and things you would talk with your medical provider about if you're deciding whether to be DNR or not, because depending on where you fall in this category, then it's important for you to know your reasonable expectations if something happens like that. So that 18% of people who do survive and make it out of the hospital, what happens to them? Well, it turns out that not all of them go back to their previous lifestyle. About a third of them do go home, but another third goes on to a long-term hospital, meaning that they still need continued medical care at a facility. A quarter of them goes to a nursing home. That's the SNF, so it's a nursing facility. And about 8% of them goes to hospice, which means that they have less than 6 months to live typically. So again, all of these are important to know, because when we're making a decision about whether to be DNR or not, it's important to know, okay, even if I make it out of this event, if this happens, am I going to go back to my usual way of life? Because the brain during cardiac arrest, having no pulse, does not receive oxygen, the longer the brain is without oxygen, the more chances of disability. So that could mean, for example, stroke-like symptoms, weakness, unable to speak, unable to see, or problems with memory or other brain type injury problems. So this is very hard to predict, if not impossible, up front. So all we have to go by are these statistics as far as in general, who is able to make it and who's not. So when is DNR appropriate? It's appropriate when a person thinks or sees that the quality of life after resuscitation would be undesirable to that person. So again, this is very personalized. What does that mean to have an undesirable quality of life? Well, that's something you have to decide for yourself as far as how much disability or lack of being able to do things constitutes an undesirable quality of life. Another point that would make DNR appropriate is if the quality of life is already poor before any sort of resuscitation happens, so in the present moment, basically, and the person would prefer death from cardiac or respiratory arrest rather than try to be brought back. Another point where it would be appropriate to be DNR is if it would result in medically ineffective treatment. So, meaning that trying to resuscitate wouldn't succeed in prolonging life or getting a spontaneous heartbeat, meaning bringing the person back. For example, if someone is in NICU and is very sick already and has multiple organs damaged, let's say kidney, liver, perhaps brain, heart, all these are already damaged and they're not expected to be able to be repaired, then trying to resuscitate that person is not going to result in prolonging life in a lot of those cases, because the underlying organ damage is already there. And even if that person is brought back in terms of their heart beating, that will not change the other organs already being damaged. So that sort of decision is important to keep in mind when making that decision. On the flip side, when is full code appropriate? So meaning that the person wants to attempt to resuscitate. So if the resuscitation has a reasonable chance of prolonging life and the person has indicated that the quality of life before and after resuscitation would be acceptable. And those two things it's important that those two things are fulfilled because obviously, when making that choice, the quality of life as that person sees it should be acceptable before and after resuscitation. Again, with the limited information that we have, no one has a crystal ball to be able to tell exactly what's going to happen. But with as much information as we have, given the conditions of the person's medical state and all that, making that decision as best as we can. So the form that actually states whether someone wants to be full code or DNR is the POLST form, or Provider's Orders for Life-Sustaining Treatment. This is also available on that website I mentioned. The form simply indicates if that person wants to be DNR. It's a legal document. It's signed by the patient and his or her healthcare provider, typically a primary care provider. And other documents can be used to express the DNR wish, but from a pragmatic standpoint, having a POLST is the most likely way, most efficient way for your wishes to actually be fulfilled. Because if you had a document somewhere within your trust, let's say, that said this, but your trust is not readily available to the healthcare providers that are giving you healthcare, then it's almost as if that document didn't exist because they don't have access to it, so they don't know. They have no way of knowing that that is there. So having a POLST that is clear and in the medical chart that labeled as such is the best way to do that. In addition, having a medical bracelet that says DNR, if that's the wish you want, is very important. And I recommend this for anyone who decides to be DNR, because a medical bracelet is what paramedics and EMS looks at if something happens in your home or when you're out grocery shopping or something like that. When you're not in the medical system, when you're not in a hospital, they might not have access to your documents. So a bracelet is a quick way to be able to know that. This is important because if your heart stops and you're out grocery shopping and the paramedics get to you, the default is to start CPR. So unless they see a clear official documentation of this, which a medical bracelet would be an official way of documenting that, then they will start CPR. And if that's not what you want, then that's not good, if that's not what you wanted. Now, I will say that Wyoming honors other states' pulse forms. So if you already had a pulse form from another state, that's fine. Just make sure that your current doctor has a copy of it on file. Signing a new pulse revokes previous ones, kind of like the POA. So if you did have a pulse at some point in the past, but you want to renew it or change it, all you have to do is do a new one, and that revokes the previous one. Again, assuming the relevant people have access to it. Now, one thing that I want to point out in terms of when these situations arise is something called clinical momentum. Now, clinical momentum is a situation where when someone has been started on a certain medical path to treat a certain condition or conditions and is in the medical system, those processes have kind of their own inertia to keep going. So let's say someone is in the ICU and is on a ventilator, on a breathing machine. Well, that in and of itself is likely to continue unless there is a change in medical status, meaning that person doesn't need that medically anymore, or someone, presumably a healthcare power of attorney or family member who has decision power over that person, decides to stop it. Now, what that means is that that way of treating will continue unless something happens. This may not be necessarily the best approach or course of action, but the fact that it started means that there's momentum in a practical sense. So there is a way to kind of step back and try to avoid this momentum when it's not appropriate. And that is by making sure every single step that is major in terms of medical care is consented to and justified. So for example, if someone is in a regular hospital bed and there is a decision to move on to the ICU because of a change of medical status, ideally that decision should be discussed, consented to, and justified. Now, if it's something emergent and it happens quickly, that may not happen. But other things like, for example, cancer treatment, if someone has cancer and the cancer is found to have spread, then the decision may be made to continue cancer treatment or not. That decision should not, in my opinion, be made by default. It should always be consented to and justified in the vast majority of cases before going on to treatment. So that means discussing with the doctor as far as what is expected from this treatment, what happens if that treatment does not happen, and so forth, and alternatives. Same goes with medication. It doesn't have to be that drastic. Even continuing a certain medication is its own form of clinical momentum. And some medications don't have to continue throughout a lifetime. That kind of just depends on the individual medication and the medical conditions at the time. But again, it's reasonable to step back and ask, okay, first of all, are we continuing this? Why? And am I being fully informed about continuing this course? Goals can change. If the health status of the person changes, then goals may change, and that's okay. But discussing it should be the ideal. This is where having a strong advocate is really important. So someone who knows you, who will stand up for you when it comes to making tough decisions and will follow your wishes as you previously stated. This is where it's really important to have that person if you do know of someone who can do that for you. Now, of course, medicine has limits. Medical interventions can only go so far. And technology oftentimes can prolong life without necessarily prolonging quality of life. Sometimes prolonging life prolongs suffering and not much else. And these are really tough decisions to make when deciding whether to continue a certain intervention or not if the only outcome that can be seen is prolonged suffering without significant quality of life following that. And of course, this might be obvious, of course, but death is inevitable eventually for everyone. And as obvious as that is, sometimes people forget that. Sometimes people forget that we all have a limited time on this earth. And remembering that is useful in these tough situations, because sometimes we just have to realize that maybe this is it. So this usually, the next point about over-interpreting small improvements, I have seen this more in a hospital ICU type setting, but it can happen in other settings. This is where, for example, someone is, again, to use the ICU example, in the ICU, very sick, maybe one or two organs are very sick specifically. But then because of the way ICUs work, labs are drawn every day, testing is done regularly. And let's say a particular lab is a little bit better today than it was yesterday. There is a tendency for some folks to overinterpret that and be overly optimistic about what that means, without keeping in mind the big picture of how sick this person may be and whether that person may come out of this major illness or not. So those small improvements, because we want to hold on to hope, can be, useful to retain hope in some sense, but they should be interpreted cautiously in the context of what the big picture is showing as far as whether this person is going to recover or not. So that sort of thing is another thing that should be discussed openly and honestly with the medical team to help guide you as far as whether this small improvement is an indication of an overall improvement or it's just kind of a variation day to day, but it doesn't change the big picture. So going on with the theme of potential end-of-life situations, something called comfort-oriented care is where the doctor or medical system, with your consent or the consent of those who are making decisions on your behalf, stops attempts at making curative treatments and focuses on keeping the person comfortable. This really is reasonable at any time, just if that's what you wish, but it's especially pertinent if there's a terminal illness. And again, based on your wishes, if the quality of life that you see ahead of you with the information you have is not going to be something acceptable, then focusing on comfort-oriented care makes sense at that point. Now, comfort-oriented care is kind of an umbrella, wider term. A similar term, but not exactly the same, is something called hospice, which is a more official designation indicating that a doctor or medical provider reasonably does not expect that person to survive longer than 6 months. That's an official designation because of the 6-month parameter. And the reason why it's official is because it may have some implications as far as whether the doctor refers you to hospice, meaning a system of caring for a person that focuses on not only their comfort, but also helping cope with the death that is soon to come, and also help those around the person, family members, to cope as well. And hospice can be very useful in that sense of providing extra support beyond just a medication that makes you feel comfortable. So this can include mobilizing resources to have help at home, certain medications, home equipment, nursing home admission. It also has some insurance implications as far as insurance paying for some of these more readily than if hospice was not invoked. So to conclude, it is very important to plan ahead so that we can make a difference and reduce the chaos and avoid as much as possible unwanted procedures and processes, and as much as possible attain what, in my experience, most people would want, which is a peaceful process if things are looking to be the end of life. Probably most important is knowing yourself and what's important to you, and making kind of the decision to pursue quality of life or pursue quantity of life. Sometimes these overlap, but not always. And if they don't, it's important to recognize that and kind of be honest with ourselves about it. I have seen the danger of being in denial and the danger of procrastinating about this. And it is a real danger. I've seen how some families suffer more because they did not address this ahead of time. I have seen how the person who is sick simply dies in a more painful way. And that's kind of a blunt and crass way to say it, but I have seen that where if things are not prepared ahead of time in terms of wishes being expressed and written down and talked about with family members so that the family members are aware and are on board, things can go south, and it's just something that you don't want to see. And I try to help people as much as possible see the importance of this and prepare and think about these things and put them in writing and communicate with their loved ones about this. And then finally, a point that I think applies to this whole series, which is as much of a cliche as it is, knowledge is power. As far as the more you know, the more you can control what you can. And of course, not everything is within our control, but the more we know, the more we can attempt to really ultimately reduce our suffering as much as possible. And that is the conclusion. So thank you very much for being here and joining me for this 4-week series.